Hi everyone, and welcome back to another Corsmed MRI video. Today's topic and protocol is going to be the cervical spine. We're going to go through the entire protocol step by step inside the Corsmed MRI simulator. Let's go! Here we have the Corsmed MRI simulator, which is where I'll demonstrate how to run this protocol. But first, let's discuss how to balance the three core MRI trade-offs. In every scan, we have three key metrics to optimize: scan time, resolution, and signal-to-noise ratio. If we improve one of these, it will negatively impact the other two. So how do we prioritize between these metrics when scanning the cervical spine? Since we need to visualize fine anatomical structures like disc herniations, nerve root compression, and subtle spinal cord changes, we must have a high resolution. Some of these structures are only a few millimeters wide, and without good resolution, we might miss conditions like small disc protrusions or early cord compression. Signal-to-noise ratio is also important because we need strong tissue contrast to differentiate between the spinal cord, cerebrospinal fluid, disc material, and nerve roots. Poor SNR makes it harder to see pathology against normal structures. So for cervical spine imaging, we slightly prioritize resolution to see those fine details and nerve compressions. Then we focus on SNR to ensure good tissue contrast between structures. Scan time comes last, though we still keep it reasonable since patient motion can blur our images. Now, what medical conditions are we looking for when examining the cervical spine? First, we have spinal cord compression, spinal stenosis, disc degeneration, and disc herniation. These are best detected with T2 weighted images, which show excellent contrast between the spinal cord, cerebrospinal fluid, and disc material. Compression appears as narrowing of the bright CSF space around the cord. We also look for acute trauma injuries like ligament tears, cord contusions, and vertebral fractures. These show up well on stir sequences, which suppress fat signal to highlight edema, swelling, and hemorrhage. Finally, we check for tumors, infections, and metastases. These are best visualized with T1 sequences before and after contrast, which show enhancement patterns that help us differentiate benign from malignant lesions. For this hands-on tutorial, we'll optimize our protocol for 3 Tesla systems. 3 Tesla gives us roughly double the signal compared to 1.5 Tesla. Now this is important because we gain so much signal, we actually have more SNR than we need. This means that SNR drops in priority to 3rd place. Resolution and scan time are now more important because we don't have as much of those. We can therefore invest some of the extra signal to either increase our resolution to see finer details or reduce our scan time while maintaining the same quality. Since resolution is our priority for cervical spine, we'll mainly invest this signal gain into getting sharper, more detailed images. We'll start with a standard 1.5 Tesla protocol as our base, then show you exactly how to adjust the parameters when moving to 3 Tesla. Let's start by reviewing our hardware settings. We've selected the optimal coil for clinical practice. The coil normally used for cervical spine examinations is the brain coil. This brain coil offers an extension to go from the vertex of the head down to the cervical spine segment. That's really important for you to know because the positioning for this particular MRI procedure is often similar to how we position a patient for neuroexaminations. Now, we'll start with a sequence that will be optimized for 1.5 Tesla as magnetic field strength and a maximum gradient strength of 45 millitesla per meter. Let's first drag and drop our localizers into the viewports. Then we'll adjust our window levels to ensure we can see the anatomy clearly. We can scroll to a central slice of each acquired plane. Let's first center in the coronal plane, then in the sagittal plane, and finally in the axial plane. Now we can add our protocol sequences. A standard cervical spine examination includes 3 sagittal sequences in T2, T1, and stir contrast. We also commonly use Coronal T2 and 2 axial acquisitions in both T2 and T1 weighted contrast. Remember that this choice of sequences is just a common standard. You should always check with your medical facility that the protocol aligns with their requirements. Let's now add these sequences to our list. We'll then start by checking the planning of the Sagittal T2. First, let's set our in-plane position on top of the sagittal localizer. When planning our slices, we'll follow a parallel alignment to the spinal cord direction. We can grab our slice on top of our coronal plane and align it parallel to the spinal cord. On top of the axial plane, we ensure that the line is dissecting in the middle of the vertebral body, following all the way back to the posterior processes of the vertebrae. Excellent. Now let's set up a suitable spatial resolution for this acquisition. Typically, 3 mm of slice thickness and 0.3 mm of gap are optimal. Next, we'll add enough slices to cover our vertebral bodies from right to left, which we can see here and here. Now let's look at the parameters for this particular Sagittal T2. Remember, we're following a 1.5 Tesla optimization. Going to the Sequence tab, we can check that we have a good echo time and repetition time, suitable for T2 contrast. One of the first parameters we need to consider when we optimize this sequence for the magnetic field strength is bandwidth per pixel. At 1.5 Tesla, the frequency precession difference between fat and water spins typically is around 220 Hz, so we need to set our bandwidth per pixel around this value. Remember not to go below that number. Otherwise, we'll likely get chemical shift artifacts. Now let's find which value here is close to that theoretical number. In this case, we'll use 244.1 Hz. The second parameter for 1.5 Tesla optimization is the number of excitations, also called NSAs or averages. This value is proportionally related to the signal of our acquisition. For a Sagittal T2 at 1.5 Tesla, we typically set 1 or 2 excitations, depending on the hardware system, to get good image quality. Now let's look at something important. Notice that when we increased our excitations, we also increased our acquisition time, as well as our SNR. Now let's examine the voxel size. The voxel size is determined by the field of view size and the matrix sizes. We have here a 24 centimeter square field of view that perfectly covers what's needed in the cervical spine, from the pons all the way down to T1 and T2. So let's count the vertebrae to ensure coverage. First, C1, C2, C3, C4, C5, C6, C7, T1, and T2. Our coverage here is good. Now, the spatial resolution we have as voxel size comes from the actual field of view size divided by the matrix sizes. For 1.5 Tesla, that in-plane resolution of 0.75 by 0.88 millimeters is a good recommendation to keep. So now let's save this sequence and rename it as 1.5 Tesla. We can now run this pulse. As it's being run, we can immediately clone the sequence and set up an optimized version for 3 Tesla systems. So let's first change the magnetic field strength in our scanner settings to 3 Tesla. Now we'll rename this sequence accordingly as 3 Tesla. Let's pull up our 3-plane localizer to get back into coverage and alignment. When we optimize the sequence from 1.5 Tesla to 3 Tesla, we need to think that we have inherently gained SNR due to the magnetic field strength increase. Now we can choose to invest that extra signal either to increase our resolution or to reduce our scan time. That's always up to the medical facility to decide, according to its clinical requirements. But for this protocol, we'll first improve the spatial resolution. That means our voxel size needs to reduce to show that boost in detail that comes from having a smaller voxel size. For that, I'll opt to reduce the field of view. I'll use 16 centimeters in the frequency direction, and I'll also slightly reduce the field of view in the phase direction to 20 centimeters. Now you can see that by reducing our field of view, we have 2 particular differences. First, since we haven't reduced proportionally in both directions, we have a rectangular shape. Such a rectangular field of view is commonly used in cervical spine since it reflects the spine's structure and can cover from the pons all the way down to T1 and T2 vertebrae. Most importantly, we're keeping that voxel size at a lower value. We can even adjust the matrix size in the frequency direction slightly lower and still keep a lower voxel size or increased resolution for this particular sequence. Now at 3 Tesla, we have another important characteristic, which is the boost or increase of flow artifacts. In the cervical spine, this means a greater risk of artifacts from the cerebrospinal fluid. The cerebrospinal fluid goes from foot to head, so we need to align our fold-over direction in the same way to minimize flow artifacts. However, this foot-to-head direction may also create wraparound artifacts. To fix this, we'll go to the Sequence tab and check that fold-over suppression is set to yes. That gives us that particular dotted line we see here, which oversamples the anatomy along the phase encoding direction and prevents us from getting wraparound artifacts. Moving on to this Sequence tab, we can keep the same TE and TR, as T2 weighted contrast still remains for 3 Tesla. But now look at the bandwidth per pixel. Remember that at 1.5 Tesla, the frequency precession difference between fat and water is 220 Hz. But at 3 Tesla, it doubles up to 440 Hz approximately. So we'll set the bandwidth per pixel to around this value. I'll go with 434 Hz here. Now let's look at the number of excitations. Remember, we're gaining signal with 3 Tesla, so we can keep the excitations at 1, reduce acquisition time, while still keeping a good SNR. Finally, but not least, we ensure that we have selected a turbo factor or echo train length that works with our effective echo time. Now that this sequence is prepared, we can save it and run it. Let's now work on the remaining sagittal sequences. For the Sagittal T1 and Sagittal 𝗀, we can copy the same slice planning from our previous sequence. We can right-click on the 3 Tesla version and copy the same geometry to my Sagittal T1. So it'll be an identical sagittal acquisition. Now, let's review the key parameters for this T1 weighted contrast. We have a short echo time of 10 milliseconds, and the repetition time will be short as well. Remember that at 3 Tesla, T1 relaxation gets prolonged. So normally, repetition times for 3 Tesla T1 weighted images go between 500 and 800 milliseconds approximately. With those settings, this bandwidth per pixel, and the minimum number of excitations, we will have a good acquisition time and voxel size. In the Special tab, we can also check that we use a lower turbo factor of 2 that works with our shorter echo time of 10 milliseconds. Now we can save this sequence. For the Sagittal 𝗀, let's follow the same approach. Let's copy the slice geometry from our Sagittal T1. We can even reduce the matrix size a little in this acquisition. In the frequency direction, we still ensure that we have very good spatial resolution. The bandwidth per pixel also needs to be adjusted for 3 Tesla. Remember, we'll be setting around 440 Hz. But something very important for this sequence is its actual characteristics. The 𝗀 sequence will nullify the signal from fat by using an inversion recovery pulse. That means we'll lose a lot of signal from the acquisition. One way to recover this SNR is to use a lower bandwidth per pixel, because when we reduce the bandwidth, we also improve the signal-to-noise ratio. For that reason, we'll keep it slightly below that theoretical frequency precession difference. We'll also ensure that we have an optimized turbo factor for the selected echo time, and that our inversion recovery pulse is set to nullify the signal from fat. The TI is selected here, but the time needs to be adjusted. In 𝗀 sequences, the inversion time is related to the magnetic field strength. At 1.5 Tesla, it ranges from 130 all the way up to 180 milliseconds. But at 3 Tesla, this inversion time increases, ranging from around 180 and 220 milliseconds. We'll set this inversion time right in the middle, at 200 milliseconds. Remember that the longer the inversion time, the darker the signal from fat will appear. We can now save the sequence. Now that we have both Sagittal T1 and 𝗀 ready, we can run them all at the same time. Let's now continue with the Coronal T2. For this sequence, we'll set in plane position on top of the coronal localizer. I'll reduce the field of view to focus on the area we want to image. I'll also reduce the matrix slightly, just to match the same resolution as the Sagittal T2. Let's also reduce the matrix in the phase direction. I'll also set our slice thickness to 3 mm and slice gap of 0.3 mm. Now let's look at the planning following our localizers. I'll bring them back into our viewports. Let's scroll again to the middle slice in the coronal and sagittal views. Now the shape of our field of view is still rectangular. And to avoid flow artifacts, we must again set the fold-over direction foot to head as we did in the sagittal acquisition. We need enough slices to cover from the anterior part of the cervical spine all the way to the posterior. We want to angle our slices so they will follow the spinal cord. So I'll align it parallel to the spine and center it. We can see that from anterior to posterior, our slice package is covering the vertebral bodies well. Finally, in the axial plane, our slices should be perpendicular to that midline that dissects the vertebral body, all the way down to the posterior processes of the vertebrae. So that's the right planning for the Coronal T2. Now let's check that our parameters are optimized for 3 Tesla. Our echo time and repetition time are good. The bandwidth, however, needs adjustment. Following the same thinking as before, we'll set 434 Hz as bandwidth per pixel, and 1 excitation to match our 3 Tesla optimization. The special tab also has a higher turbo factor that aligns with our effective echo time. Our acquisition time and voxel size are similar to the Sagittal T2 with high detail for these 3 Tesla systems. So now we can save this coronal sequence. Finally, let's work on our Axial T2. I'll set the in-plane position here in the axial localizer. Let's again reduce our field of view. In this case, I'll reduce the phase field of view to 140 mm or 14 centimeters and then set the fold-over direction to anterior-posterior. By doing this adjustment, we make sure that our field of view aligns with the shape of the anatomy in this axial plane. Next, let's set our slice thickness and gap to the same values as in the previous sequences. Let's now look at the slice planning. The slices need to be perpendicular to the cervical spine when viewed on the sagittal plane. For the coronal view, we need to ensure that the slices are running parallel to the intervertebral spaces shown here. Now let's talk about coverage. Let's adjust the number of slices that will allow us to cover the entire 7 cervical discs of the C-spine. Centering that, I can ensure I have covered C1, C2, C3, C4, C5, C6, and C7. So the coverage goes well into my C-spine. It's a good practice to review the images when planning, because if you have a herniation or disc prolapse, you may want to add a couple of slices to include those discs that seem pathological. Moving to the sequence tab, we set a good TE and TR for T2 contrast. Bandwidth per pixel will again be adjusted for 3 Tesla. Our number of excitations is right. We can check our turbo factor or echo train length, also optimized for the selected echo time. Finally, something I highly recommend in cervical spine acquisitions is to use saturation bands. Saturation bands are typically useful when placed on top of motion sources. In this case, we can place it on top of the patient's throat, which could represent the motion source if the patient is swallowing. So it's really finely adjusted just on top of that source that we can see in a dark fashion here. We avoid placing it on top of our region of interest, which is the cervical discs. That's a really good recommendation to follow in MRI practice. So we're ready to save this Axial T2 sequence. To finalize the Axial T1 planning, we'll copy our slices from the Axial T2 into the Axial T1. We'll just ensure that the echo time and repetition time align with 3 Tesla. Bandwidth per pixel, same story. Number of excitations, same here. The turbo factor is now reduced for that effective echo time of 10 milliseconds. acquisition time, and spatial resolution are optimal for 3 Tesla, guaranteeing the best image quality we can get. Once we have checked that everything looks good, we can save the sequence. Now the 3 remaining sequences can be run at the same time. Let's now compare the images we have acquired at 1.5 Tesla versus 3 Tesla. I'll scroll to a central slice of each so we can see the differences. I'll keep my 1.5 Tesla sequence in the left viewport. And in the middle viewport, I'll keep my 3 Tesla sequence. Here we see how the reduced field of view creates a better spatial resolution compared to the 1.5 Tesla. Both sequences actually reflect optimal quality for their respective magnetic field strengths. That's important to bear in mind, to always work according to the MRI setting you have available. The image contrast is the same, signal is optimized for each magnetic field strength, and resolution is shown better for the 3 Tesla image. Now the last thing that's important to mention is the scan time. The scan time for the 3 Tesla sequence was almost half of the 1.5 Tesla acquisition. If we keep the resolution the same, we can even improve the acquisition time on the 3 Tesla sequence even further. So now let's compare our results and evaluate the image quality we've achieved in this protocol. We'll start by placing our T2 weighted contrast sequences in each viewport. I'll place my Sagittal T2 on the left viewport. In the middle one, I'll keep my Coronal T2. And in the final right viewport, I'll set my axial acquisition. As you can see, these 3 planes in T2 contrast show exceptional image quality. Remember that T2 weighted images are fluid-sensitive contrast, so they'll highlight the cerebrospinal fluid across the 3 planes and help us detect pathological changes involving fluid and soft tissues. This helps us check for pathologies like spinal cord compression, disc herniation, myelopathy, or cord edema. Now let's bring our sagittal stir sequence into the viewport. We can see here that the suppression of fat is optimal and of high quality. That's because it uses an inversion recovery pulse to nullify the signal of fat versus a spectral pulse. This inversion recovery pulse is robust to field inhomogeneity, so it will always ensure strong fat suppression. This lets us see the subcutaneous fat suppressed and also the bone marrow signal. In short, stir acquisitions allow us to detect bone marrow edema, inflammation, and infiltrative processes such as metastases or infections. Any inflammatory or infiltrative changes in vertebrae and soft tissues are clearly seen with this contrast. Now let's review our Sagittal T1 and Axial T1. We can adjust the brightness of our viewports, so let's do that for both sequences. Then let's scroll to a central slice in each view to visualize its contrast and overall quality. T1 sequences are great for several reasons. First, anatomical detail. T1 provides excellent contrast between fat, muscle, and intervertebral discs, as you can see here. It's ideal for assessing vertebral body integrity and bone marrow pathology, such as metastases. It also helps us detect fat-containing lesions like lipomas, as well as subacute hemorrhage. Finally, the pre-contrast T1 also serves as a baseline image before we use gadolinium contrast. The post-contrast T1 then helps us check for tumors, infections, or demyelinating lesions. Overall, T1 is critical for evaluating marrow composition, structural integrity, and anatomical landmarks. In the axial images here, we can see our saturation band on top of the throat, which helps us get motion-free images. With that, we have covered the entire cervical spine protocol. So let's recap the most important takeaways to remember. First, we slightly prioritize resolution, then SNR, and lastly scan time. The cervical spine has fine anatomical structures that need clear visualization. So we need enough resolution to see disc herniations, cord compression, and subtle pathology. SNR also matters for contrast between tissues, but resolution takes slight priority here. Second, we mainly use turbospin echo sequences for this study. These provide fast acquisition with excellent soft tissue contrast, and they work well for T2, T1, and stir weightings. Third, make sure to avoid the common artifacts in cervical spine imaging, which include cerebrospinal fluid flow, motion, wraparound, chemical shift, and truncation artifacts. Some techniques we can use to avoid these artifacts are to align the phase encoding with the CSF flow direction, place saturation bands on the throat to reduce swallowing, use fold-over suppression, increase the bandwidth, and increase the matrix size. Finally, remember to adjust parameters when moving from 1.5 to 3 Tesla. Bandwidth doubles from around 220 to 440 Hz, and stir inversion time increases from around 160 to 200 milliseconds. We can also use the signal gain to either improve resolution or reduce scan time. If you follow these key points, you'll be able to perform excellent cervical spine MRI protocols. Thank you for watching, and we hope to see you in the next video.